to sedating our patients because they're uncomfortable or because their alarm goes off, it means that whatever's causing all of those symptoms is not being resolved. We're simply putting the patient to sleep. We're not fixing whatever has our patient in an uncomfortable state, and so that's only going to prolong whatever issue is happening with that patient. We also want to check for auto PEEP. Again, we've talked about this a couple of times. Air trapping diseases like asthma or emphysema could have some auto PEEP if you don't set enough time on the ventilator for the patient to exhale. So we want to check for that. And then if you're just not sure, or you've searched for all of these things and none of these seem to fit, call your local respiratory therapist and start troubleshooting the situation with them. And then before I turn this back over to Jen, these are just a couple of pictures of asynchrony and auto PEEP. On the left-hand side, we see a horrible-looking scalar that should be a whole lot better than it is. But the problem here is that in the middle of a breath, we can see at the very far left side of that picture, the patient got a breath. And then in the middle of the breath, the patient's taking his own breaths inside of it. And the machine and the patient are just not set, the machine's not set appropriately for that patient. On the right side of the screen, we have the auto PEEP. So we're looking at the top of that picture in scalar A. Airway resistance is normal. The patient gets a breath. The patient exhales. It goes back to baseline pretty quickly. There's some baseline time there, and then another breath is provided by the patient, by the machine, and everything looks fine. All the gas is being exhaled. In scalar B, in the middle, you can see that the machine gives a breath, and the patient does exhale all the way,